Good morning, everyone. My name again is Jose Santiago. I'm Scientific Leadership Manager for Abbott Diagnostics. I'll actually be standing in for my colleague, Randy Schneider, who's actually busy today, this morning, doing a brownback session in a different place, but he was in charge of organizing this workshop for everyone today. So welcome again. It is a pleasure to welcome you to this, our third Abbott-sponsored workshop at ASCC. Our workshop this morning is entitled Leveraging Clinical Decision Solutions to Standardize Clinical Interpretation to Achieve Healthier Hospitals. As probably you've heard already in the past couple years and maybe even the last couple of days, it is estimated that approximately 70% of clinical decisions are made based on information that's provided by the laboratory. But what kind of decisions are made based on the information that we provide? And are they good decisions? Are they well-informed decisions? And are they really providing good results in terms of ensuring the short and long-term institutional sustainability, maximizing the operational efficiencies of institution, and most importantly, ensuring that the patient outcomes are improved? But what if the laboratory could leverage currently available informatics-based clinical decision support decisions to ensure that we are empowering our healthcare providers to make more consistent, better informed decisions? Decisions that could have measurable impact to reduce clinical variability, to bring down costs, and ultimately to improve the quality of care. This will be the central focus of our workshop this morning. So without further ado, I'd like to introduce our first speaker for the day, Dr. Julie Taylor, who recently retired from the CDC. She's a health scientist from the Centers of Disease Control and Prevention, or CDC, where she was part of a division of laboratory systems, Clinical Laboratory Integration into Healthcare Collaborative, or CLIC program. This program's vision was to improve laboratory test selection, result interpretation, and test utilization. Dr. Julie Taylor received her master's and PhD in microbiology from Auburn University, and then she went on to complete a postdoctoral fellowship at Emory University, also in Atlanta, in virology. Throughout Dr. Taylor's career working in both the private and public sector, Julie has identified, developed, and completed programs addressing the unmet needs in clinical care. So please help me welcome Dr. Julie Taylor.
Great. Thank you so much, Dr. Santiago, for that very warm introduction. And I would also like to thank Dr. Randy Schneider and his colleagues for inviting me to be here today to talk to you about a subject that affects us all, not only on a personal level, but also in our professional lives. And that is diagnostic error. And I'm also going to talk to you about how we might be able to use clinical decision support tools to reduce diagnostic error and improve diagnosis. The Institute of Medicine, which is now called the National Academies of Sciences, Engineering, and Medicine, just recently published in 2015 the 8th series of the To Err is Human report. And this report, the 8th one in the series, is called Improving Diagnosis in Healthcare. In that report, they stated that each one of us, unfortunately, has the opportunity to have at least one diagnostic error in our lifetime. That's something we don't want. We want to focus on improving that. I can share with you the one that I've had, and I hope it's the only one I ever have. I was 13 years old, and I was having fainting spells. I was passing out at school, which as a 13-year-old was kind of scary. My mom took me to the doctor. They ran tests, glucose test normal, not epilepsy. They began to look for brain tumor. I was very upset about this as a 13-year-old. Mom was concerned too. She took me to another doctor. They did a glucose tolerance test. I have a problem with management of my glucose. So I went on a diet, and now I can manage my health, and I have not had any more fainting spells. But I do not remember how many of those spells I had before they diagnosed me and put me on a diet and got me treatment. I mentioned that diagnostic error affect us professionally. We're in the clinical lab area. Clinical lab tests are a huge proponent and support for diagnosis. So we have a big, I guess you say, bucket to carry to try and help improve diagnosis. So today I want you to think throughout our session about how clinical decision support tools could be used in your own healthcare facility to help you improve your clinical lab test utilization, all with the end goal to help you improve the diagnosis in your healthcare facility. This is an outline of what we're going to talk about today. Talk about diagnostic error, physicians' challenges with test utilization, and interactions between physicians and laboratory professionals. I'll share with you some ideas for CDS tools and solutions for improvement. And I'll give you my own account of what I went through in the development of a CDS tool to hopefully maybe give you some insight into what you might be experiencing if you try to develop one in your healthcare facility. I mentioned the National Academy's report. In the report, it states that diagnostic error is the failure to establish an accurate and timely explanation of the patient's health problems. Now, even if we get that correct, we still could have a diagnostic error if we do not get that information to the patient and have the patient treated. Those two things could cause a diagnostic error. In this report, they talk about the magnitude. 5% of U.S. adults will experience a diagnostic error when they go to their primary care doctor. 10% of patient deaths are due to diagnostic error based on post-mortem explanation. 6 to 17% of hospital adverse events are due to diagnostic error. And you are 2 times more likely to, and diagnostic error is 2 times more likely to result in patient death and the highest proportion of total payments in medical malpractice claims. So we have a problem right now focused in the area of diagnostic error, and we want to improve diagnosis. I showed you this slide, but many of you, seems like I'm getting feedback. Am I doing something? Okay. This is a slide showing the Dr. George Lomberg brain-to-brain total testing process that you probably remember from years ago. But what I want to do is focus on, in this slide, the one green box, the analytic phase, because that's the phase that you control, and that is why there are less errors in that phase than any other phase of the total testing process. So you can pat yourself on the back. You've done a great job with that. But what I want you to do is try to get out of your box. I want to take you out of that box and have you help us, with your knowledge of clinical laboratory, improve the 2 areas that really need to be addressed, and those areas are test ordering and the result interpretation, the other end of the scale after they get the results, the physicians, what are they going to do with the results, how they can utilize the results to help the patients. So once again, I'm going to challenge you today, hopefully, to think about how you might be able to help us with this. A study was reported by Dr. Hardeep Singh, who works at the Houston VA. He looked at the types and origins of diagnostic errors, and he found by reviewing electronic health record-based triggers, these triggers were based on patients' unexpected return visits after a primary care visit. He looked at two large healthcare systems. One was an urban Veterans Affairs facility, and the other was an integrated private healthcare system. What he was looking for was missed opportunities to make an earlier diagnosis based on retrospective EHR documents. What he found was 190 diagnostic errors out of about 200,000 patient visits, which is not a huge amount, but it's not acceptable. But what they looked at in these 190 is the types of cases that they were seeing, and they identified 68 unique diagnoses that were missed. They identified that most of the errors were in the patient-practitioner encounter interaction. And in that interaction, they found that most of the errors were due to missing the ordering diagnostic tests for further workup. So it's on that other end of the spectrum of using results. They also identified referrals and patient-related factors, and I'm not going to get into that. You can read the article if you're interested. But they found about 15% of the errors were in the area of follow-up and tracking of diagnostic information, and about 14% in the area of performance and diagnostic tests. I've highlighted in red the ones that clinical decision support could help. So those are the areas that need help. CDS could help. I had the privilege of finding out about this workshop. There was a National Academies held a workshop all day in Washington, D.C., and it was broadcast live, so I was very happy that I found out about it. But what it was that they brought together people from around the country to meet in Washington to discuss what have we done since this 2015 report of the improving diagnosis in healthcare. What has happened? And more importantly, what are the areas in which we still need to focus? What do we still need to do? So it was an all-day discussion. And to be honest, I didn't listen all day. I couldn't quite sit all day. But I listened to the in summary. And I put on the slide some of the things I heard in the in summary. They are going to probably write a report, and I have websites and references at the end of my talk, including this particular one. If you want to listen, you can go online, and it's available now to listen as much as you want to the whole day session. But what I want to point out is at the end of the talk, in the summary, they said the top issues still are cancer, vascular disease, infections. And the top focus area that was discussed that needs assistance is failure to close the loop on test results. Once again, that's an area that they even stated in their summary that CVS can help close this loop. So now I'm going to talk about some work that we did looking at physicians' challenges. Dr. Santiago mentioned that I just retired from the CDC, and I worked with a group called CLIC, which is an excellent work group of experts from inside CDC and outside CDC. I was very privileged to work with them. But I wanted to take time to introduce. We have a new lead. I'm very happy because I'm gone, and she's taken the reins of this clique, and her name is Dr. Colette Lamont, and she's here today. You want to raise your hand. So if you need more information about the clique work, she's here and can help you with that. But what I want to tell you is during the talk today, I'm going to share with you some of the publications and the data that we collected with this group. The first one was that we conducted a survey of physicians, and we had over 1,700 physicians respond to the survey, and it was a mix of family physicians, internal medicine physicians. And what we asked them about was their communications with laboratory professionals and what they had problems with and challenges in test utilization, and, of course, what their suggestions were to improve. they reported that they saw about 81 patient visits per week. And of that, they want to order laboratory tests about 1/3 of the time that they're with these patients. But what was alarming was about 15% of the time, they were uncertain about what laboratory tests to order. And about half that, they were uncertain about what to do with the test results. This has the potential to impact millions. We also asked them about uncertainty in test ordering, and we found that they go down the hall for curbside consult. They review e-references. I want to focus on that. That was one thing that they are going back to, is reviewing e-references. I did want to point out, you can look at all the data that's available in the publication, but I want to highlight what they didn't do. In the last thing in frequency is they do not ask a lab professional. Only 6% ask lab professionals. We asked them about what they do when they're uncertain in result interpretation, and the one thing they thought was very, very useful is review e-references. So they're used to going to the computer for information, so therefore they are okay with computer technology. Once again, for interpretation, only 6% ask a lab professional, which we all know if they would come to you, you could help them with both of these, test ordering, result interpretation. So what about communications? Why are they not talking with lab professionals? We published an article in Lab Medicine just this year, and I encourage you to read it. We also have a blog if you want to blog, and I have a podcast if you are interested in reviewing that, and it's all listed here. So this article was to understand physicians' communication with laboratory professionals, identify tactics for you to use to become more recognized members of the team, all with the goal of improving diagnosis. What we asked them was about how they describe themselves related to the diagnosis process. And 71% use electronic resources. Once again, they're used to using the computer. And about 60% use a core set of lab tests. They will tell you that they have no trouble with lab test utilization, but if you find out more detail, it's because they're used to using 20 lab tests. They're comfortable with the 20. Outside that, they are not. This slide, we asked them about frequency and helpfulness of physicians' communications with laboratory professionals. And I put on this slide to highlight the never. They never, 48% never ask lab professionals about the medical significance of results. They never ask lab professionals about assistance with follow-up testing, that's about 43%, or about 6% assistance with appropriate test ordering. And we know you could help. So they are not asking you. But if you look at what they are asking you about, which is what they always have counted on us, is for the technology, the technical side. Where are the results? Tell me about the test. They asked about the technical, but not the clinical significance or relevance of the lab test. I also put on this slide some bars where you look at the black and the red, and here you'll see we asked them about why they do not consult. They say, too difficult to contact a person who can answer a question, don't know whom to contact. But we did find, when I asked physicians about this, I'll have two different groups of physicians. One group of physicians say, oh yeah, I call Bob all the time. He's a great guy. He knows all the stuff in the lab. He knows everything. And I find out that he's known Bob. He knows him personally, and so therefore he can go down the hall and talk to Bob. But if they don't have a relationship with the lab, they don't call. Where did they get information about the lab tests? Because that could help us. If they're going to be doing diagnosis, they need to know the latest information to get to a diagnosis quicker. So what they are doing is about 80% continuing medical education, once again, electronic professional articles, so they're used to going to the computer. But as you saw on that slide, they don't ask lab pathologists or sales because those are the people that would know the most about the new test, but they don't want to ask. This slide shows we asked methods to improve, and on the graph I have percent that said they were available, these are methods, and the percent that said they were very or extremely useful. I put them in two groups. The CPOE, computerized physician or provider order entry with electronic suggestions, things to help them when they're ordering, were the least available at the time, but over 50% of physicians said they were very extremely useful. What was least useful was just CPOE. As a matter of fact, some of them said CPOE alone sometimes inhibited them because the systems weren't very effective and they weren't easy to use. So we want to focus on going towards the CPOE with suggestions. Trending reflex testing and interpretive comments were available, and they liked to use them and thought they were helpful. So in summary, physicians are uncertain in test ordering and result interpretation. They don't contact you, but they are willing to utilize clinical decision support tools. So what are we going to do about it? This particular definition is found on a website that I would encourage you to go to, and it's healthit.gov. It has information about implementation tools. If you're going to get involved in clinical decision support, it has a lot of information about clinical decision support and health IT. But they state that a process for enhancing health-related decisions and actions, and here's the key, with pertinent, organized clinical knowledge, and patient information. It's not just a cookie cutter of sending out a guideline. It's including all that together to improve health and healthcare delivery. I have listed here a slide from an article by Jason Barone, Dr. Jason Barone and Dr. Anand Degay from Mass General, and Jason may be here. He presented, I hear, a wonderful workshop or session yesterday. But they've done some great work in the area of clinical decision support. But this article was focused on CPOE and how it could help improve the clinical laboratory. So what they are saying is CPOE could include these items for you. If you want to develop tools, look for having things that would help with ordering templates, alerts for different types of test orders and corollary test, displaying previous data so the physicians don't have to order it again to get the information, practice guideline integration, and cost. But I want to caution you about cost. Do not just let physicians make a decision about the lab test based on cost, because some tests, such as genetic tests, even they're more costly, but they get to the diagnosis quicker, save costs downstream, and save patient health. Another thing that he published is that this is, another report by Dr. Aziz, that we could have standardized formats for result reporting. It'd even be better if you could have where physicians could customize their report. So they would put the information with the way they see things. Alerts for critical test results, results pending after discharge, and we've already talked about the other items that are on the slide. So I'll give you my thoughts about CVS Development. This is just a simple model, and it's a couple points I want to make. You need to start with what are the areas in your clinical lab, in your healthcare system, where the physicians need the most help. And you start with that. So you need to identify a knowledge gap. Then from that, you need to develop the clinical information to take care of that knowledge gap. Now, I want to point out, a lot of times we think, oh, that's IT. That's, the IT people. They should be doing that. I put you down this clinical content second, because you can't have CDS tools without the clinical content. The IT people will not know what to do, so we need to have clinical content. And then you need to partner with the IT to get the CDS tool developed. We identified, when I was working at CDC, a gap for prolonged partial thromboplastin time, and this was based on that Dr. Michael Laposada, who was on our CLIC work group, and Dr. Marissa Marquez was on our work group, And they said they get calls all the time where physicians don't know how to manage these patients. Now, if you're getting a few calls, then you know it's a bigger problem because they're not calling typically. So this was the problem that they wanted to address, and there are various reasons here why. Consultative services, you guys aren't available every day to help them, and on-the-spot training is not appropriate. So we thought this was a good place to start. This is just a general flow of the way we developed it, and basically you could look at it in buckets. One is that you identify experts to develop the clinical the clinical content, and then after that, you do a scientific review. Once you get your first base down of the clinical content, you get others. And this is all based on review of evidence-based guidelines, published reports, what is out there, and you have clinical experts review it and decide what is the best flow, what is the best clinical content. What we had to do, of course you probably will too, is you have a legal review. Now you're here at AACC, and it may be that you're here, you're meeting other people outside your facility. You may find people who you want to partner with in developing a CDS tool, and in that you may partner with them, and if you do, you may have them sign external licensing because you want to use it in your facility, and that is something that you might consider if you're working with people outside your institution. Then you need to go back to your institution because you have experts there, you have physicians that might be using this content, you have other people. So there's a lot of review and discussion before you get to the final clinical content or algorithm. And of course, the best way to get a review of your clinical content is to publish a peer review article. And that's what happened. We have an article that is published in the American Journal of Hematology, and this is one of the algorithms that's in there, and it's not to challenge your site, it's just to point out how complicated these tools can be, this clinical content can be, and also to show you, okay, you have this now content to help a physician with a prolonged partial thromboplastin time. Are you going to hand that to him and let him or her carry it in their pocket? How are they going to utilize it? Some people, some healthcare facilities have websites, great websites with all their algorithms. You can go and look. I've done that. And you may find that those are ones you want to adapt. You don't have to do this process. But if you think that there's a better way, and we thought, well, what could we do to make it easier for them to use? So we decided to develop a smartphone application where you just have it in the smartphone. And therefore, you take one little note at a time, and it comes up one page at a time. So what we did was we identified the target audience for us were primary care physicians because that's who we wanted to help. And we had to determine the format. When you develop a clinical decision support tool, you will find there are a lot of options out there. And you may find one that's available already so that you can just plug and play and it makes your life easy. You don't have to develop something from scratch. But you can look in the literature and find out what's available to you. And if you want to develop your own, you need to partner with your IT people to do that. And then you go through the process of testing. You have to test it offline. If you have a clinical decision support tool in your healthcare facility, you're not going to just put it out there and mess up everybody's data. You have to do it offline. When we have a mobile app, what we have to do is we have to test it through beta testing offline. So then you do the beta testing or your testing, and you go through security and privacy review, legal review again. And then, if you're doing an app, you publish it in the App Store. And here is the quick read code. If you have a smartphone with a reader, then you can just hold it up and you can download this app here right now if you wanted to. That's what that's for. Or you could go and look at it through this particular website. So it took that complicated algorithm with all those steps and put it into a step-by-step. Each little decision tree is on one page. makes it easier for the clinician to have this. And we found that many clinicians use their smartphones while they're with patient and to help with patient care. So they already have it there with them to be able to use. This is an article we published about the process. If you want to read more about what we did for the development, you can go there. And I want to close with diagnostic errors cause patient harm and extra cost. The contributing factors are that physicians reported uncertainty in how to use diagnostic tests, and physicians do not ask laboratory professionals. We know that. So they're having a problem, and they're not asking the people who could help them. So what can we do? We need to improve test utilization, improve patient care. One decision is clinical decision support tools. And the key is you, the laboratory professional. And I want to mention something about, I think I still have a little time, is that right? I don't know if any of you use a smartphone or some kind of navigation app when you travel. I do. I'm not good at navigating, so I use this all the time. And my app comes up with, you plug in where you're going to go, route A, route B, route C. You get to pick whichever one you want to go. And I was using it about 2 weeks ago, and it came up with a little green thing that I clicked on, and it said, quicker route available. And that's why I'm driving down the road, quicker route available. So I clicked on it, turn left at the next intersection. So I got down the next intersection, and ahead of me, if I hadn't turned, was completely stopped. There had been an accident, and it came up immediately on my phone that there was a problem. Now, who are the experts who are putting data into that app? Who knows most about when you're going down the road, what the conditions are on the road? It's the drivers. So the app I use, drivers put in the data for everybody else. Instantly, when they put in data, one thing that keeps coming up is pothole ahead. If you have that. So instantly, they're down the road, they put it in, and immediately everybody has that information. Why can't we do that to get physicians to get to the right diagnosis, to get the right route? And it should be similar. It should be that when we have a clinical decision support tool, it gives clinicians options, route A, route B. We don't want to take away the ability of the clinician to make a decision. These CDS tools should be just augmenting their decision process, but gives them the options to get there quicker. And shouldn't it be that if we have a new lab test come up or a new guideline, that immediately we can upload it and all the physicians in your healthcare get it at the same time? You don't have to do what they said they go to, is looking for CME training programs, going to the web and searching. Is it not possible that we could provide this to them pretty easily in their normal clinical workflow? It seems to me that if we can get to Uncle Freddie's wedding quicker using an app, why can't we help a physician get to a better diagnosis? So with that, I want to encourage you, because I mentioned the drivers are the key to the navigation app. Who are the people who hold the knowledge to put the CDS tool in for the clinician? It's you. So unfortunately, it's going to be on your shoulders to update and make sure the clinicians have the information that they need to be able to get to that diagnosis quicker. With that, I'm going to go to my resource slide. We have resources listed here, and the first one is the actual report that I talked about, the 2015 report. The second one is the information about the workshop if you want to listen to the summary or any part of it. The third thing is a group that I want to share with you. It's called the Society to Improve Diagnosis in Medicine. They have organized, and Paul Epner has been a real leader in this area. They have organized a group that is taking on trying to improve diagnosis and address this IOM report, or the National Academy's report. They have a great set of resources for you. They have tools. They also have a coalition. How many of you know whether your healthcare or your group is involved in this coalition? Because some healthcare are joining this coalition, and what you do is when you join, you help with some aspect of improving diagnosis in your own healthcare facility. But you can learn more about what others are doing in the nation to improve healthcare by going to this website. Also, there's an implementation guide that you can find, and I mentioned this IT health resources that might be useful to you to find about implementation and other things related to clinical decision support tools. And then I mentioned earlier about the CLIC group. There's their website if you want to learn more about what they're doing, and they're going to be coming out with more tools and things to help. So hopefully you'll follow them. And I have a last slide, but I don't think we're going to have questions right now. Is that, Jose? But what I did want to point out is I'm retired, and I needed to make a disclaimer. I'm sorry, I forgot. I'm retired from CDC, so everything I told you today is from my own perspective. It's not CDC, it's not from the government, it's just Julie Taylor. So don't ask the CDC that Julie Taylor said this, and so come see me. That's my email address. But I hope that I've stimulated you to get involved. Thank you. I'm gonna get my way. Thank you.
Thank you so much, Dr. Taylor, for such a wonderful presentation. I'd like to now introduce our next speaker. Our next speaker is Dr. Eugenio Zabaleta. He's a clinical chemist at Ohio Health, Mansfield Hospital. He also is a lecturer at the Cleveland State University Graduate School and Clinical Chemistry Program in Cleveland, Ohio. Dr. Zabaleta graduated from the Catholic University of Cordoba, that's in Argentina, with a degree in biochemistry, and received his PhD in chemistry from the University of Akron, Ohio. He received his clinical pathology training at the Hospital Provincial San Roque in Cordoba, in his native country. He was the laboratory medical director at the Clínica del Sol, neonatology intensive care services. Dr. Zabaleta also completed a fellowship in laboratories of specialized clinical analysis in Cordoba, and then he ended up at the doing a fellowship with the Ohio Health Mansfield Hospital, where he's currently residing. So it is my pleasure again to introduce Dr. Zabaleta, and please join me in welcoming him to the stage.
Ooh, I think,
oh, you don't have a... He's not mic'd. Oh, here.
do you hear me? Yes, you do. So thank you for inviting me, and thank you for the kind introduction. I don't think I deserve it that much. But my part of the talk is, so I have been hearing for many years Dr. La Posata, Dr. Taylor, and everybody, and I work in the middle of nowhere, and you will see I am nobody. But so if I can do this, I start developing with my own hospital. If I can do this, everybody can do it. So the only thing is you need a little touch of madness. But besides that, so I am showing you over here that our hospital, originally we were separate. All the work is done in these two hospitals of Ohio Health. Ohio Health has 12 hospitals now, and most of the work is done in these two. And I have been working on this for the last 12 years. So I will try to give you, I will show you only 3 projects that are tangle, and they are a progress of work of almost 10 years to show you how clinical decision support and the knowledge, because it's all evidence-based, but it's also about the practice of medicine. So you need to rely on the medicine that you and your doctors are practicing. This is not about IT. This is about the practice of medicine. So the only thing that I want to tell you is we are in a city that is 50,000 people. Our hospital is more commensurate with a community hospital, so I told you I am in the middle of nowhere. And we have a very big, that's why the examples, we have a big cardiac program, and a lot of the things that we were doing as part of meaningful use stage for the High-Tech Act. So we have a very strong IT that we were developing during all of this clinical decision support. So with that, I will go back to supplement one slide that Dr. Taylor used, and this is the George Lumber, and if you see, you have over here the physician trying to order, and this part, the pre-analytical and the post-analytical, like Dr. La Posata wanted to talk, happen in the EHR. And all of our pre-post and analytical part, the laboratory box, happen in the LIS. So if we want to help the physician, we have to get out of our comfort zone, the lab, right? We need to go where the patient is. Not only, so they create 12 years ago this position, that my position, I am not a director, I don't have any power. My role is to be a bridge between how the lab is performing the test, the analytical performance of the lab, and how the clinician use it, clinical performance of the laboratory test. So, for the laboratory, I am a trader, and for the physician, I am a spy, basically, right? So I walk a line into, and my job is actually push people out of their comfort zone. Wow, I have the best job in the world. For living, I make people uncomfortable. Anyway, so if you see the Institute of Medicine, and I will show you that the diagnosis error is, like she say, and I want to repeat this, inaccurate or delayed diagnosis. So, if we drew a sample, and we don't like the result, and we keep it, oh, I want to a redraw, and after that, no, just in case, I want a redraw, and a redraw. 3 days later, the doctor get the result that they needed. So why we don't communicate? I am having this result. Is clinically possible or no? Can we develop tools to help our technicians, laboratory technicians? Because in the collective knowledge, the PhDs, the MDs are not as much as important as the medical technologies. All of us, we have the collective knowledge of the clinical laboratory medicine. So we need, so this actually, and I will show you in action, all of those are the goals for improving for that report. And I have been working on those 5, and I will show you them with examples. So the first one is about teamwork. The second one is about education and training. And not only about formal education, but we are talking about what we need from each other. That leads to the first one. Creating the evidence base and know in every place we can practice the same. So in an academic, the same medicine, in an academic center, we have certain expertise that in a rural hospital we don't. So when we should send the patient and start getting the best for the patient, not for us. Using information technology to leverage that technology support. Oh, about talking about education and closing, one thing that Dr. Taylor say is CPOE. when done correctly and develop, so CPOE is, the doctor is over there, you develop order sets. And order sets are the group of order that are appropriate, and when evidence-based, they are the appropriate for that disease or that workup or that clinical care pathway. This is a word that I want laboratory need to start working on clinical care pathways. When they are doing good, we can educate on spot. We can actually put embedded, and I will not be able to show you because they gave me only a stingy 40 minutes, and I can talk for 5 hours. So, sorry, I am complaining. So, when we can educate on spot with literature. The next thing is a deploys approach to identify and learn from diagnosis error, and we do that all the time, and I will show you some examples, and establish a culture that supports the diagnostic errors, and sometimes that is very well linked to number 2, right? So I have been doing in some way or other, because each one of these have a sub-goals. Number 6, my institution have done it, that is create the culture of blame-free and start being able to learn. And the other 2 is the government, and I don't have any pull on that, right? I am very far removed. But the interesting thing, and maybe with this I can sell you this guideline, number 7A, it has 2 sub-goals, says that as long the fee-for-service model exists, they suggest CMS to develop a CPT code that everybody in the diagnostic portion can use each time we help the physician order the right test. So they are trying to get payment for what we should be able to do. So, the thing is, on top of that, we work for the patient, right? And sometimes we start talking about us, the physician, the nurses, and we forget about who we work for. So there are some in the center of all of this, some call patient, right? And the triple aim try to get the patient engagement. And so the first one is improve patient experience of healthcare, including quality and satisfaction. Have you ever heard about the very famous HCAP? That is how they evaluate us, but they don't know about medicine. So we need to start thinking about how they see the value of our work in other terms. The other thing is improving the health of population. So, hold on. Isn't this about patient-centered care, and they are talking about population? So, is it personalized or is not? Is the government confused? No, actually no. What it means is we have enough data to support that when there are a lot of clinical variability, and there are more probability for errors. So if we start creating clinical pathways and standardize to the best evidence-based medicine and put it in the context of the resources of that hospital, you improve care. And the last one is, if you do that, you are having, and the patient is engaged in their own treatment, you start reducing the capita per cost of healthcare. So, if we start thinking about laboratory medicine in a patient-centered care, and this is our structure over here, the instrument, the LIS, all of the different systems. However, to do clinical decision support, we have to go. We can have a clinical, and I will show you 2 projects driven mainly by this, but where the patient live really? In the EHR. So if we confine our expertise only to the walls and the IT infrastructure of the laboratory, we are missing the biggest opportunity to help. And I will try to show you examples of that. So when I am talking about improving diagnosis of healthcare and CDS, clinical decision support, is a structure that I think in 3 legs. And a structure that has 3 legs, if one is broken, what happens with the structure? It falls, right? It doesn't go anywhere. So for me, evidence-based medicine, IT infrastructure, and teamwork are paramount. So, and I am going to try to convince of that. So, in 2010, we went live with a project that was born way before, and we were trying to identify the first troponin increase alert. So this is what happened. One physician came and said, we need, and it was in the process improvement actually, we need to identify an alert of clinical significant troponin values. What happened? This is what happened. A patient was in the doctor's office. The doctor did an EKG. The patient was having ST elevation AMI, and they admitted, go directly to the hospital, no problem. The patient was a 72-year-old female with always a baseline of troponin of about 2. And in our test, the normal value at that time was the WHO cutoff, so it was extremely high. It was about this high. So this patient is always abnormal. She had a congestive heart failure, renal chronic kidney disease stage 3. It was having always essential hypertension. And in that moment, she was having exacerbation of the COPD, sorry, and that triggered the AMI. So she goes, is admitted to the hospital. If you see, it got stable very quickly, 2 days later. But the 3rd day, she does another peak. Because of all of the comorbidity and the very low management of pain, she was very heavily, for her own choice, because we were having the pump, and you know that they can dose until the... So it was a very high increase in troponin. Nobody saw that troponin increase over there, so she had a AMI over here and have a second AMI, because with all of her comorbidities, bingo, for having another one, right? And always the second AMI is worse than the first one if you are going to have more than one, because the clot is producing one and it goes downstream, or you can have multiple disease, multiple artery disease. So nobody saw that result until 36 hours later. So they say, who didn't see this? Is this a responsibility of the laboratory? Is this a responsibility of nursing? Is this the physician responsibility? However, whatever it is to blame is, can we do something to avoid that 36 hours of nobody doing anything? And the patient, because she was rested, she never had shortness of breath. Well, that we noticed, all right? She was sleepy, she was almost dying, and we didn't realize, right? So the thing is, they say, oh, okay, in the emergency, we have a cutoff value that is the abnormal. So if we will call over here, in this, there are 8 measurements, only 2 measurements are significant for an AMI. So are we going to be calling every single, our techs will be living on that, we will also, nursing will be calling all the time. So we analyzed the data and we saw that in a month, we have a 1,600 result. 323 we will be calling on the inpatient. if we use the ED cutoff, and only 61 were meaningful. So how we can do this? So it was clear that nursing couldn't handle that because we have a high turnover. So the laboratory was singled out in the process improvement. You guys, each time that you result, you should look back. And I say, no, you cannot do that. The productivity will be horrible. So the thing is, I say, okay, we were building for meaningful use, and clinical decision support is one of the things for meaningful use. I say, until that moment, clinical decision support, everything was concentrated on nursing processes. I say, why we don't use it as a laboratory? And everybody looked like you are crazy. And probably I am. But that is not the point. I say, it will help nursing, it will help everybody. So what we did is, this is, so you over here you see the two walls, the laboratory over there, the physician. So the physician will order troponin using the CPOE, and after that, we will do the result, we will put it in the EHR, but at the same time, we will send it to a clinical decision support inside the laboratory. It will review, and when an alert, one of those increases is produced and identified, the tech is automatically notified to call the nurse. But at the same time, we give an interpretation, and an alert is posted on the doctor's role. All of the doctors are associated with that, because if that patient have, like, for example, endoscopy or another procedure, but the troponin say, okay, no, here is something more important. You cannot take this patient to a procedure, and they will, so even we improve their workflow. So the thing is, in our EHR, the doctor see the result. So this one went from almost not detectable to a detectable, and after that, the big increase. So our normal value is higher than this. So the thing is, at that moment, they didn't want me to put the 99 percentile. And you will see this discussion going on during the years. This is 2010. So the alert that we were calling was when it was higher than the WHO cutoff. So the doctor, we will call and impact in that way. However, they let me put another less important interpretation when the increase in troponin was less than the, higher than the 99 percentile, but less than the WHO cutoff. I wasn't happy about that. So when we went live with this project, cardiologists told us, we don't need this. And I will tell you that they were right. However, the problem was the patient not under their care. And they soon realized about that. So we did a study, and I don't have too much time, but in the cardiac group, so there were people admitted to the cardiac services and non-cardiac. In the cardiac services, we didn't find a statistical significance between pre and post. So cardiologists were under control. That wasn't the problem. In the non-cardiac services, half of the people over here were consulted with cardiologists, so it was another group. And in those also no statistical significance. But from the patients that they never saw a cardiologist, this is what happened. So a patient comes to the ED, they have a chest pain, they do a rule out of pneumonia and all of PE and AMI. So what happens is they see an infiltrate in the lungs, they say, ha! It is pneumonia. Let's send it to the floor. It's pneumonia. Next, right? I am done. Well, that is, but they never follow up and rule out AMI. So they go to the floor because of CPOE, and I couldn't explain too much, but we put on those moments, we realized that we needed to put the 3 orders of serial troponin. They were already put. So it doesn't matter where the patient went, the order was. And this was a good idea, but you will see it was a bad idea 4 years later, you will see. So the thing is, at that moment, we realized that we decreased the length of stay of that group by 1.7. If you calculate, it's about 36 hours. So what the doctors were claiming, it was still happening. How often it happened? Between 14 to 16 patients a month. That is an unbelievable number. So what happened is we realized that there are some that didn't change because the diagnosis didn't change. What they have is a high troponin due to a sepsis. One was an overdose and an attempted suicide in a cold basement in January. So all of those patients were having cardiac arrest due to other things. But the other one, if you see, 47% of the alert was originated 6 hours later from the admission, from the time that they did in the ED. So these patients were having the AMI. 60% 12 hours later. And the other one is 24. All of these will have, and there are some dispute about this, because if we will have used the 99 percentile, all of these will be high within 6 hours. So in that patients, by reduction of the day, we have a saving of 300,000. So with that data, and in 2012, we were already applying for meaningful use, so we were very busy on everything. So the third universal definition of myocardial infarction came, and I say, we need to move to the 99 percentile. And they told me, okay, Eugenio, we have more important things to do with all of the meaningful use. Also, at that moment, I was doing a project I cannot show you over here, that it was identifying patients at high risk for, it was a clinical decision support, a high risk for readmission on chronic, on congestive heart failure. We did that tool, and we tried to recruit it to the nurses following those patients, because in 2011, the readmission rule for congestive heart failure was start going to penalize us. So we were doing that with cardiology, so sometimes we cannot take a lot of projects at the same time. We are not a huge academic center, right? So in 2014, the American Heart Association and the American College of Cardiology guideline was there, and they say the 99 percentile of troponin is the cutoff that you want, eliminating other cardiac markers, and flagging abnormal troponin. And I say to them, with the clinical decision support we have, I can do that. I can do, because in that moment, a lot of places in the country, they couldn't flag what was clinically significant. So the recommendation is clinical laboratory reports should indicate whether significant changes in cardiac troponin value for particular ASA have occurred. I can not only do that, if not, I can do a whole full interpretation. So the thing is, they told me, well, let's see, and in that moment, patient-centered care took a stage. So that's why I include that. So our ED were having terrible reviews for the HCAP. That is where HCAP start being predominant and being public. So the hospitals say, we need an observation unit that is a clinical decision unit that will take the patient from ED, improving their throughput, and do protocol-based rule out of troponin, stroke, and another disease. So the thing is, they put me on the working team in the protocols. So when we start analyzing utilization is because I told them in 2010 that they were missing troponin patients because with my previous, so I was a prisoner of my own success. They started ordering troponin on everybody. Actually, in one, the most ridiculous, but I have other examples, it was the diagnosis is right toe ischemia. You wonder where the heck that person have the heart, right? Some anatomical defect, I guess. Anyway, so we start working on this, and the idea was we will not put the 3 orders anymore in the ED. The ED physician will do the first troponin, transfer it to the observation unit. When the observation unit doctor will do the evaluation, will do a risk assessment tool called the HEART, and HEART stands for history, EKG, age, risk, and troponin, the first troponin that is done in the ED. With that, they classify patients in low, moderate, intermediate, and high risk, and those are the major percentage. So all of that, the problem with that is the approach of this needed the hinges, the success hinges on physician education and communication between the provider. And with this project, I learned that a lot of over and underutilization is due to lack of communication between them. So the thing is, this is what we wanted to achieve, and also decrease the use of troponin, not only improve the outcome. But the problem is, so I went to, because all of my projects, I told you, I am nobody, need to be approved by the medical council. So I go and explain this, and the person in charge, it was a surgeon, he told me, are you crazy? You want us to take out all of the serial troponin measurement, and you have shown us that we are missing 14 to 16 people a month? So I say, okay, the question was, can we improve laboratory test utilization without putting patient at harm or risk, increasing physician hospital and hospital liability? So the thing is, I come up with a crazy idea. I come up with that. And you say, what the heck is that? Right, so that is what I call my sorcery thing. So it's a clinical decision support that is going to look at the patient chart and say, okay, you are forgetting this. So this is the way that it works. So the doctor sees the patient, order the troponin test, see very automated troponin test we are having, right? And so after that, we give the result, it transfers to the admitting physician. That the sorcery thing will say, doctor, you have only 1 troponin in the ED, you didn't put at admission any other, you have 2 choices. Further troponin are not indicated, and you order that and you commit to that, or because there are clinical reasons, because you remember there were overutilization in the ED, and further troponin, and they can put the order right there without even entering the patient chart. So when they put the order, the alert discontinue, and I go back to the council and they say, are you crazy? What happened? Sometimes we are ignoring alerts. So I say, okay. And a lot of people told me that this was a terrible idea, and it was a terrible idea. So I say, okay, if there are no response in 2 hours, and the alert, the sorcery thing will send a page, and that person will be calling the physician and put the order, discontinue. For 2 months, the pager was in my hip, and that was a terrible idea. However, I learned so much, and I cannot share that over here because I don't have time, and I am running out of time. So the thing is, in 2 months there were 2,123 patients transferred from the ED. I received 603 pagers. Most of them, 70% 2% occurred after outside first shift, when I was in the hospital. Most of them, 47%, 57% occurred during night. I didn't sleep literally for 2 months. But it's wonderful. I learned so much. People were angry with me. They swear at me. They ignore me. Everything. It was great. So we found that 319 didn't need further troponin. That was a cost containment. 284 needed further troponin, and that is improved utilization. 32 patients had a clinical troponin that we will have missed. If you divide that by 2, it's 16. So the medical director of the council was right. I was wrong, right? So the thing is, with that, and also, I didn't make the 603 calls because sometime between I wake up, log in the computer, find out who I need to talk, the doctor will put, and that happened within 7 minutes. The furthest I will call is 7 minutes, or I will call. Some of the patients will put the alert later, just in the moment I was logging in. So in 76, so we were being, especially that happened at night, when there are one hospitalist for the whole hospital. So that guy or woman cannot be everywhere, right? So the thing is, after that, the nurse in charge of each ward was receiving the page because I couldn't deal with that. So from that, I have to tell you that we analyzed the patient that we didn't follow up with troponin testing, and they were not readmission within 30 days, no major cardiac event within 30 days, and no death. So we were safe in stewarding, because this was a laboratory test stewardship, basically, and right now the nurses were doing it. So as a direct result of this process, we decreased cardiac markers in the ED by 28.1%. And that number still holds. So this is me. This is a CAP. I tell you, some people do whatever it takes to be in a publication. There are people worse than me because they become mass murderers or things. I just didn't sleep for 2 months. So this is the day I am surrendering my pager. Did you see how happy I am? You can see it in my eyes, actually. I was tired. So in 2017, right now, 1 month ago, we went live with a new interpretation based on, after we become safe again, we kick a little notch on the interpretation according to the 2014 guideline, and this is still being implemented. It's impacting a lot of patients. I don't have data because we went live on the June 23rd, but I have a lot of anecdotal data. So the thing is, in this project we are doing serial troponins. We are looking not only for a first increase, but also for any increase or decrease when it's higher, the first value, the 99%, we are looking for 20%. It's a different from our previous project. And this is the biggest change for our physician. And the decrease is because of the late presenters. So if a person was having an AMI, especially in a place like us, and you have to know your demographic. We have a lot of, I don't know if you know, that in Mansfield, there were a very big GM plant that in 2008 shut down. So we have a lot of people that before had insurance that now they don't. So some of the people trying to don't go to the hospital when they have a chest pain and they go 1 week later. So in those patients, we are having to detect the late presenter, the peak is already gone. We are detecting the going down to the baseline. But those people still had an AMI that need to be further investigated because a clot, an active clot, could be traveling and do a second episode like the first patient I show you. I show you that case because of a reason. Actually, that project was triggered by 7 patients, not only that one. So the thing is, right now, I am using the same, the same clinical decision support. So the problem with clinical decision support is for the first project, you have to build everything. But after that, you just change the rules. So that is what we are doing, and I will show you how it's working. So right now, these have changed because of adopting the guideline to the maximum extent. Now 2 weeks ago, we changed it 0, 3, 6, right? But the protocol. But in this one example, if you see, the first one is normal because we are using the 99 percentile. The first significant change and is require urgent notification. We create an alert that the nurses wanted in the medical record because this is attached to a clinical pathway that need to trigger a consult with cardiology. So cardiology can see if they were notified at the right time by looking at so we are providing workflow information too. So if you see over here, those report, I didn't want to also say, yes, it changed, but what it means, right? So if the physician click over there, it say consistent with acute myocardial injury. All of this was developed with the presence of the physician and the nurses. Because when you develop something without the nurses' involvement, they can make it fail first, but second, they will not be able to communicate to the physician because they cannot understand it. So it's the whole group. So this one, for example, still went up, and between this and this, there are a cath lab procedure, so there are an insertion of a stent, the troponin keep going up, but the doctor doesn't need. Cardiology is already involved, and we know for our previous data that our first analysis or research that cardiology are safe. We knew that there are no clinical significance. And right now we are not doing, because the guidelines talk about interpretation during a 12-hour window, we are not doing any interpretation over here, but we are analyzing if we really want to start analyzing like a combination of the first troponin alert plus this, because if a second episode happened, but we are analyzing with our physicians. So the thing is, what I wanted to tell you and I have 45 seconds, so I want to give you the keys for you to be successful as I was. So we need to establish a strong lab physician teamwork, and those are the 3 pillars that our physician champion developed, that is respect, equality, and understanding each other, strength, weakness, workflow, but also regulation. We have different regulation, and they need us to do certain things because of that, and they need to do certain things because of us. CAP and all of that, have you ever heard about that? So, analysis of current process and commitment to change, clear projects, goals, and objective. I include each project like I use the scientific method, and I will, yes, 1 minute, give me 1 minute. Lab hospital administration commitment, you need to have a laboratory champion that is a physician. It cannot be a pathologist. need to be a physician because they need to be in the other side to understand the impact of your work. Analysis of pre and post metric implementation. Close the loop, learn. The project will have certain unexpected outcome, and that could be good sometimes, but over time, everybody get complacent with the new rules and start finding loopholes, and you need to retweak, retrain, or your physicians that develop the other start changing, so now you have different expertise. So that is important. The number one misconception of clinical decision support is that they are IT projects. No, it is all about clinical care, patient care. It's about evidence-based medicine. It's about increasing patient safety, and it's about avoiding diagnostic errors. Thank you very much. Sorry.
Thank you so much. Thank you so much, Dr. Zabaleta, for such a lively and great presentation. That was only after one cup of coffee, by the way. So I'd like to invite both speakers to come up for a quick Q&A session. We have a couple minutes. If anybody has a pressing question that they would like to ask, I would like to invite you to the microphones and share your question with the speakers. In the meantime, while you're gathering your questions, I'd like to ask a question maybe to both of you. Clinical evidence-based medicine guidelines sometimes are lagging behind. So there's this trade-off that has to occur between how to implement these guidelines into clinical practice and are balancing with new research that comes up that may be coming up. What was your opinion on how to balance the frequency to which guidelines are renewed and what needs to be best for clinical care?
You go. So in our case, so when there are clear guidelines, everybody agree, everybody go great, and there are very few spontaneous hair loss, right? So the thing is, when it's not clear, you now have to start looking at second-tier papers and very frontline research, and you have to start taking the consideration of the board of your own expert. So maybe what your clinical decision support will look in your institution with certain level of expert in that area will be different, like Mayo Clinic or other hospital that has more resources. So the thing is, sometimes if you bring things from other institutions but you don't have the expertise to support it, it will fail, and actually it could be worse for patients. And we review the literature periodically. Every guideline, new guideline, is an opportunity for the laboratory to show its value, so I will go and present new things, and always I am looking for problems, right? So that's why when I go at the beginning, they start getting a little feisty, because it's like, okay, what did you find now? What we are doing wrong? But it's just, they know that it's to help.
Well, I would just like to say that I always felt like guidelines kind of have to follow behind what the latest best practice might be, because it takes so long to get the best practice and get data and then to have a guideline. And one of the things that when I first joined CDC we were looking at are evidence for what are the best practices in lab medicine to reduce errors in lab medicine. And because you guys in the lab are always busy working, you don't publish as much. So there is also a lot of gray literature out there when you do a project and it's not an official peer-reviewed publication, but it might be somewhere in your database, somewhere in your healthcare system that you have evidence from your own practice, but it doesn't get out and get published. So
it would be nice if we could figure out a way how to get our learning from our individual institutions somehow into an area where they could be shared, and we could say, like, well, this institution did this, that sounded like a good idea, let's try that. And then once we get enough evidence, then we could then turn it into a guideline. And then, of course, working from the federal government's perspective, the regulations are way down the line, so we have to try and keep those up as well.
One thing I want to, that is what happened with the cardiac troponin project, because I was telling the physician about clinical, we didn't agree on what we call a clinical relevant, but I was alerting the physician 4 years earlier than when the guideline suggested to do it. So after that, I just wanted to update it with the best evidence and do the interpretation, but it took me 3 years.
In the interest of time, we're going to save the questions till later. I'm sure that you'll be available for one-on-one questions after the session.
Yes.
We're running a little bit short on time. I'd like to encourage you, everyone, to fill out your evaluation forms and comments and leave them for you or turn them in on your way out. Lastly but not least, there's the PACE credit information. If you guys need it, there's also PACE information on the forms that you have in hand. And lastly, I wanted to make sure that encourage you and invite you to come to our 4th workshop, which will happen this evening. It'll be on advancements in hematology. We'll be presenting and sharing some of the information on the Alinity HQ Alinity solution. Great. Do you want a question?
Yes, very quickly, a very quick comment and a question. I believe we need increased effort in the standardization and validation of CDS tools based on the latest evidence, and also increased effort in evaluation, because the results are mixed in terms of effectiveness of CDS tools. My question relates to the use of artificial intelligence that is being increasingly now used, particularly in the field of oncology, where very sophisticated, complicated systems clinicians resort to in order to do the right therapeutic modalities, to do the right testing, and implement the most effective strategies in patient management. And those tools are really in real time, because, you know, the computer Watson is one model system where they evaluate the latest data in the literature, in the medical literature, that could be a week old, 2 weeks old, and based on effectiveness render judgment. So it may be increasingly not only clinician laboratory professional, and computer systems in terms of better optimized patient care. I would like to get your reaction to.
Well, I think that Watson, I followed Watson's work, if you might call that. I think they had Watson at the Cleveland Clinic, and it was doing a good job of doing some questions and answering some of those questions. I think that there's maybe a place for that. I think we have to caution that, once again, it doesn't take the place of good clinical judgment and patients. The physician knows the patient better than Watson would. But I think there's opportunities to utilize all types of technology to improve our care.
No, I was referring to use of artificial intelligence as support, not as a substitution.
Yes, exactly.
Right.
Yes, because the definition of medicine, what is the definition of medicine, is an art and a science of curing people, treating people, and all of that. So still we have a lot that we know, and the intuition of the physician is still very important. So in part of, and there are an art to choose the right science, and there are a science to execute the best art. So because of that nature, we are not like in other areas that the knowledge is more hardcore and more basic science. I think that in biology, because of all of our genetic variability, they haven't figured out 100% of the variables.
Yep.
I think that probably no even 1%.
Thank you.
Well, thank you very much. And with that, I'd like to thank our speakers again, and thank you all for your attendance, and enjoy the rest of your day.
Thank you.